Hi, welcome to Fairview Range Focus. I'm Deb Boardman, CEO at Fairview Range, and we bring you this monthly program about healthcare topics that are of interest to you in the community. And today I'm very pleased to tell you that we have Dr. Paul Lindholm here with us, who is our radiation oncologist, and he's going to talk a little bit about our radiation therapy center. So welcome, Dr. Lindholm.
Well, welcome. Thanks, Deb.
Why don't we start by talking about what exactly is radiation treatment?
What is radiation treatment? Well, radiation is one of the best understood cancer treatment modalities there is, to be honest with you. The history of radiation and cancer treatment goes back to literally the purification of radium from pitchblende by the Curies over 100 years ago, as well as Professor Röntgen designing the X-ray tube. And it was discovered anecdotally early on that malignant tumors would shrink when they're exposed to radiation. So, of course, it was very infant science at that time, but it's grown into what it is today.
Very interesting, thanks. So let's talk a little bit about what actually is in the Radiation Therapy Center here in Hibbing.
Oh, well, we're primarily, as most cancer treatment centers are today, an outpatient-based treatment center. So patients come and go from home to get daily periodic treatments, just like they, well, that's the way most chemotherapy is given as well, outpatient centers. So typically radiation therapy is given with what's called fractionated external beam therapy, so that a patient comes for a course of treatment on a daily weekday basis over a period of somewhere between 2 weeks and up to 8 weeks, depending on the disease and the treatment intent.
So I think some people are a little bit confused, Dr. Lindholm, about what a medical oncologist does compared to a radiation oncologist. Could you help clear that up a little bit?
Well, sure. Basically, radiation oncologists' treatment modality is radiation, various forms of radiation, for the most part X-rays, to a lesser extent electron therapies, but medical oncologists prescribe what people think of as the drugs, the chemotherapy, mostly intravenous drugs and other types of oral chemotherapy agents. But no, our one big hammer is always some form of radiation therapy.
So you've been here a while.
Well, seems like yesterday. 16 plus years.
Well, and we're very fortunate, obviously, to have you in this community, and you've been a big force in developing the Radiation Therapy Treatment Center as it exists today. Would you be willing to share with us a little bit of the history of how that came to be and why we're where we are today?
I'm sure you must be trying to make me blush, apparently. I actually looked toward northern Minnesota many years ago, around 1990 or so, and I thought, goodness, there probably could be a radiation oncology practice up there. We're primarily a population-based, specialty where it takes X number of people, in a sense, to fill a need and create a need for a specialty. So the seeds of this were sown a long time ago. I can't take credit for the initial development, but I will say that conversation between myself and the then CEO of the hospital, Fran Gardeski, ultimately it led to this. The University of Minnesota was involved in some outreach up here. They've had a long history of this relationship with Fairview as well. And eventually, after I guess throwing the ideas out there, I started getting phone calls from the university and saying, was that your name that we heard, that you'd like to come up and practice radiation oncology in Hibbing? And I will say it was an awkward dance for a few years and a few stumbling blocks, but the center opened in 1996, and I moved up within the first year, spring of '97, when they were having a little bit of trouble, hiring and keeping a doctor. And I was 40 years old, and it was kind of what I thought then was a midlife decision and a leap of faith. Turns out midlife comes about 20 years later.
Yeah, for true.
And I couldn't look back and have made it any better. I really think it was a wonderful decision on my part. And
so there wasn't a center here prior to the time you started?
No, there wasn't. Now, back in the old days, There was some radiation therapy up here. There used to be a little bit of rudimentary radiation therapy that was done in and around diagnostic radiology departments, what we now call diagnostic imaging. So if you go back historically, there was a little smattering of radiation therapy here and there, but what we think of as modern radiation therapy didn't exist in the Iron Range until 1996 to 1997.
So that was the original building, and machine came in the 90s, mid-90s.
That's correct.
And
right.
then the new machine that you have came about 3 years ago?
About that, yeah. 2010, we moved into our new department. We basically doubled the size of the department. When I say we, it's really you.
All of us.
All of us, yeah. And being a hardware-based specialty, being dependent on high-tech equipment, you always have to make a decision now. Are we going to expand the department? Are we going to maintain it? And we've done a good job, I think, keeping our department up to snuff with plenty of redundant capability, the ability to shift patients from one machine to another, essentially doubled our treatment size in 2010. Not so much for the need of capacity, but because it's very difficult for us to swap out new technology to replace old technology. The downtime and the interruption to patient care is just intolerable. So no, we've got a good-sized department, more than capable of taking care of everyone up here in the Iron Range, I would say.
And people travel quite a distance for these types of treatments, do they not?
Well, yeah, it's an interesting perspective. When I first started out in practice 20-plus years ago, it seemed very common for patients to travel even 100 to 200 miles or more for radiation therapy. I mean, if you think about those days, the only radiation oncology practice up here was in Duluth at Miller-Dwan Hospital. And today, our International Falls patients feel like they're traveling from the end of the earth to come here to see us. But of course, you just have to change your perspective. But yeah, I would say our patient demographic, I mean, we have the Grand Rapids patients, International Falls, East Range by Waback, Aurora, over that direction. Yeah, people do travel quite a bit.
I think we talked a little bit about the building itself, but let's talk a little bit about how patients actually get referred to the Center for Treatment. How does that occur? Oh, sure.
Well, most patients that come to see me are referred from another specialist, usually a surgical specialist, medical oncologist, etc. Or likewise, I'll refer patients back to medical oncology or hematology oncology if need be. All the surgical specialties, general surgery, ENT, head and neck surgery, thoracic, etc. Many different specialties all work together. Of course, patients that are perhaps established as our patients will self-refer, or their own primary care doctors will refer them back to us for management and further input. So, you know, I guess I like to see it as a lot of different specialists working together, all for the care of the patient is a priority.
So you don't have to necessarily be seeing a Fairview physician, for example, to be referred for treatment?
Absolutely not. I shouldn't go out on a limb and say I think we have a great working relationship with all of the specialty groups and independent up here in the Iron Range.
Okay. If a person has never been there before, maybe you could walk through the process from the time a person gets referred the first time and you meet with them. What happens when they get there?
Well, it's very much like a patient-doctor visit. Patient comes into our department, they come into a waiting room area, they're checked in, insurance information, everything else taken care of, and most of the time there's already a chart or patient record started where we have information, imaging studies, history, et cetera, But a lot of people who are intimidated that think they're going to come in and see me for some kind of odd interaction, or perhaps surprised to find out it's really just like going to see a doctor. It's really just about a doctor and a patient. And so the process is very much like going to see any other specialist. You meet with the nurse, take history, past medical history, medication lists, et cetera, and then meet with me on a consultative basis, history, physical exam, sort of review and verify other findings, pathology, imaging, and all of all of that complementing, the basic core material. And then we formulate a treatment plan.
So that's probably the next thing we could talk about.
Sure.
What actually happens when a person gets radiation therapy treatment?
Okay, well, the process of coming to see me, going through the consultative process, the next step in order to move on toward a treatment program is basically a scheduling phenomenon. We schedule a treatment planning session, which in this day and age, for the most part, involves a fancy CT scanner, which we call a simulator or CT sim. Patients are positioned, immobilized, et cetera, for comfort and position reproducibility. All of the scan information is taken, put into a big magic computer system. All of this used to take place without big magic computers now. Keep that in mind, okay? Nevertheless, this is how the process flows now. So, as I always tell the patient after that planning process, which is scheduled maybe in an hour or less, now you go home and relax and we'll come up with all the hard work behind the scenes. So the next time you come back to see us will be to get started with a treatment course, and you're scheduled in a daily, weekday, 15-minute time slot for daily treatments. That's about it. Really just a logistical, scheduling phenomenon after that. And of course, during all this time, the process, my nursing staff will talk to the patient, as will I, about what to expect for progression of treatment in terms of side effects and things like that. I see all my patients once a week or more to go over side effects and see if they need other medical management, things of that nature. So that's sort of, how the process takes place from consultation to treatment planning to day-to-day treatment.
When you talk about putting someone into a 15-minute time slot, the treatment really isn't for 15 minutes long, is it?
Not at all. No. Typically, actual treatment times, there's more time spent with our therapists setting patients up, positioning, and verifying for treatment than there is treatment delivery. Treatment delivery, really, we're talking on the order of, a minute, 2 minutes, half a minute, 3 minutes, that sort of thing. Typically in several short to medium length bursts, because most radiation treatments are delivered with a combination of beams from different directions. So actual treatment times are, like I said, typically a fraction of a minute times 1, 2, 3, 4.
And so for those people that are non-lay people like me,
okay,
when you talk about that, what you're doing is you're guiding this image or this treatment directly towards the tumor or the area that you've identified that needs treatment, correct?
Right. We've come to think of this as target volumes. In the old days, we used to think, two-dimensionally a lot. We'd picture patient anatomy and organ and tissue anatomy in 2 dimensions, and we tend to look at anatomy and shapes that way. In today's modern radiation therapy planning, everything is done almost like it's a volume basis. We're collecting axial or CT imaging through a patient, and literally every 2.5 millimeters through a patient's body, we're coming up with a shape in that particular plane that we want to deliver a radiation therapy dose to. So by the time we're done with the plan, we can come up with a very complex, convoluted combination of beams that delivers what we call a highly conformal radiation therapy treatment dose, and spares as much as possible tissues that we don't want or need to irradiate.
So what you're explaining, I believe, has to do a lot with this new machine that we have, all the computer aided and all of this. I'm fortunate in that I can be behind the scenes, and I've had the opportunity to see what these 3-dimensional scenes look like, and all the computer work and all the computers and people behind the scenes that make this happen. Could you just explain a little bit for folks what this IGRT, right, image guided,
IGRT.
is?
Well, yeah, there's everybody has to have little catchphrases, IGRT, IMRT, all these funny little isms that become catchy and glitchy. Now they are useful. They are useful terms. I don't mean to belittle them. But yes, the terms you hear commonly, intensity modulated radiation therapy, simply means a way of modulating the shape and intensity of a radiation beam such that we can create combinations of beams that almost make it look as though radiation goes around corners and treats targets that are hiding behind other things. It's kind of a remarkable phenomenon to see. And then IGRT is sometimes an extension of IMRT and sometimes an idea in and of itself where treatments are image guided either daily, or the newer talk is intrafraction guidance, where radiation therapy is delivered in bits and pieces when we can image and guide and see that anatomy is indeed shaped and arranged the way we want it to be. And there's kind of a smooth continuum of using that technology from one end to another. Some as simple as say, well, we're only going to treat the patient when the breath is held, when the chest cavity is expanded, or we're only going to treat it when the chest cavity is empty. Or those are just simple compensatory things that we use those concepts of IGRT and IMRT for. It probably sounds like a lot of gobbledygook, and it is, but it's useful technology.
It works.
It truly is. Well, in fact, you mentioned the guidance. Our radiation therapy treatment machines, the linear accelerators that do the heavy lifting of what we do, deliver all of our treatment, the technology we have available for image and guidance on these is amazing. In the old days, when you had a regular X-ray fluoro simulator or treatment design machine that was kind of like a low technology X-ray machine that you'd have all over the radiology department, we don't even have any of that equipment anymore. It's all CT and axial imaging based and computer based. The idea behind that being what we call virtual planning and virtual sim. The localizing and imaging technology now exists right on the linear accelerator, the machine that does the actual treatment delivery. In fact, we even have a CT scan right on the treatment machine. It's called a cone beam CT. The technology is interesting in that the way the CT scan is generated, it allows us, instead of using the big round CT scanner that most people are familiar with in a diagnostic radiology department, this thing generates a CT scan literally while the patient is set up for their treatment. We take a verification scan. My therapist can localize the treatment to a spot. I mean, they typically are moving these things a millimeter or two. They'll say, Dr. Lindholm, is this okay? Our biggest shift was a millimeter, to which, of course, I say, yeah, you guys are pretty accurate, pretty accurate. So the technology truly is remarkable. It truly, truly is.
Well, I have known people who've had radiation therapy, and we kind of jokingly laugh about it because they end up with a little tattoo, do they not?
Very commonly. Usually we'll have, and this is variable from department to department, but I think most departments will leave one little permanent tattoo and with records so that we know how we can set up and reproduce treatments that have been given on a prior basis in a previous year or decade or whenever. Yeah, the tattoo is a very common part.
And it's just a little dot.
It's a little tiny
little
dot.
Teeny dot.
It's nothing decorative. No.
No designs or no any of those things.
No,
right?
we don't do that. That's extra.
Okay.
Yeah.
So what actually goes into determining how much of a dose of radiation that a person gets?
Well, a lot of it is the type of disease, the treatment intent. As everybody knows in medicine, you know, some healthcare is delivered, some medicine practiced for the purpose of curing disease, some is practiced for the purpose of alleviating symptoms and pain and suffering. In the general internal medicine practice, of course, much disease is not cured but treated on a palliative basis. And I always find it interesting as an oncologist when people say to me, well, you're a cancer doctor, that must be very depressing. Oh my goodness, it's not depressing at all. Sure, everybody in medicine has their ups and downs. There are good stories and bad stories. But oncology is so much curative medicine as well. And people don't seem to have that perspective. Everybody knows the bad stories and the sad stories. So, but typically, you know, not to belabor the point, longer and longer treatment courses, generally we're talking 6 to 8 weeks, are associated with treatments for diseases that we treat aggressively and curatively. shorter and shorter courses, maybe on the order of, 5 weeks, or I'm sorry, 5 treatments or 10 treatments or 15 treatments are typically associated with diseases and diagnoses that we're not treating with a curative intent. And there's some crossover there. There's a trend toward shorter courses for curative diseases in certain applications, and it's probably a little too complicated and difficult to waste our time talking about that right now. But suffice it to say, treatment lengths vary. Generally, like I say, from 1 to 5 treatments to 35 or 40.
Do you have a sense, Dr. Lindholm, of what percentage of patients that have cancer end up with some type of radiation therapy?
Yeah, over the years, the numbers that come to mind have always been like 50 to 70%, and whether I'm more confident in 50 or 70, I couldn't tell you right now, but it's in the ballpark. Certainly most patients that are treated for cancer at some point are going to end up seeing someone like me.
Okay. We have a tendency in healthcare to think about when we come to the clinic to see our physician that it's just a physician, but there are many people that work in your area, in your department.
Absolutely.
There's some folks behind the scenes that contribute to the work that you do in determining how much radiation a person gets, and the nurses that take care of patients. Do you have a sense of how many people work in your department or how big you are?
Oh, absolutely. We've got reception staff, 1 to 2, one full-time nurse position, which is filled by 2 to 3 therapists, the people on the treatment machines doing the actual work. There'd be 4 people there, not 4 FTEs, I don't think. But, so, it's certainly a couple of handfuls of people. And behind the scenes, dosimetry, treatment planning expertise, medical physics, which is a huge integral part of what we do. Can't slight those people at all.
No, for sure.
And so, yeah, 4, 5, 6, 7, 7, 8, 9, 10 people typically in a department our size.
Sure.
Yeah.
So how many treatments a month do you do? Do you have a sense?